Good evening, everyone. Thank you for inviting me to talk about coronary dissection. Similar to my colleagues, I won't be talking about left main dissection. I'll be talking about dissection, though. So my topic is treatment options for iatrogenic occlusive coronary artery dissection. So I'll jump straight into the case. This is a 75-year-old female with known coronary artery disease, previous PCI to the OM with 2 drug-eluting stent. She had also a history of pericarditis, pericardial fluid. She underwent a pericardial fluid drain with samples sent to the lab, and it was EPP positive, treated with colchicine for 6 months, diabetic, hypertensive, rheumatoid arthritis, Paget disease of the nipple, planned for excision. Patient was symptomatic, has exertional shortness of breath with minimal effort. Patient was planned for stage PCI of the LAD. It was heavily calcified. Echo was normal. So we'll jump right into the case. The image on the left is the diagnostic angiogram, severe stenosis in the mid to distal LAD, which is heavily calcified. The plan was to use OCT and plan calcium modification. Minor hiccup in the cath lab when advancing the OCT catheter into the LAD. There was prolapse into the circumflex artery. I don't have any images fluoroscopically of this happening, but we were able to advance the OCT catheter, performed shockwave, and then stented the LAD. As the case progressed, we were taking our final shots for the LAD. Patient was still having some chest pain, and I noticed a new lesion in the proximal LCX. So no wire, patients having chest pain, ST elevation, and we decided to do something for the LCX. Initially tried wiring with a soft taper tipped wire. However, this resulted in progression of the dissection. So I just wanted to remind myself and my colleagues about classification of coronary artery dissection. They range from type A to type F. We're going to see progression of coronary dissection in this case. First attempt was done to rewire the artery with a soft tapered tip wire. This resulted in further propagation of the dissection and patient having more chest pain. This is when we decided to wear on my CTO cap and progress with CTO equipment. So the plan was to fenestrate the false lumen and try to gain access from the false lumen into the true lumen. So incidence of coronary artery dissection is variable, 48% in the POBA era. However, currently it's less than 1%. Mostly it's due to inappropriate handling of guide catheter and inadvertent subintimal passage of the guide wire. Treatment, there's no standard technique for restoring vessel patency. Treatment is left to expert opinion, and results are variable. Most times we fail in revascularization and need to send the patient for an urgent CABG. Treatment options are multiple, and I think it depends on what we are comfortable with. Antegrade wiring with a soft tip load wire such as the SOHO 3 I think is the first approach. Then star and contrast guided star. Last, using a microcatheter and stiff guide wire. Antegrade fenestration re-entry, Stingray system, and IVUS guided re-entry. So I decided to use a microcatheter and a Gaia third and started fenestrating the false lumen. This resulted in flow back into the circumflex artery. However, as you can see, my Gaia third wire is still in the subintimal space. However, because I have restored flow, I was confident that there is a passage. So I kept my Gaia third wire in this position and advanced a cyan blue wire. And I was happy that I was able to advance my wire into the distal OM2. I don't have images of this, but I performed IVUS, which confirmed I went true lumen, false lumen, and back into the true lumen. So I was happy ballooning and stenting at this stage. as you can see, the dissection started extending. I was hoping to stent initially just the entry site of the dissection. However, because of the staining progressing down, I decided to stent more distally. And then these are my final result, maintaining flow and TIMI-3. Patient's ST elevation resolved. She went back to the CCU and has recovered well. So my take-home message is, despite having a non-CTO case, CTO experience and expertise is helpful for any cath lab operator. Thank you.
Excellent. So, I'm not sure how many of you are CTO operators, but if you are not a CTO operator, how would you manage that?
Same way. Yeah, they have no option.
I mean, if you are not CO2, there are some technique they have, the CTOs, the tricks.
Yeah, if you find a new legion, you need to go negotiate that legion because it was
a lumen, true lumen.
No, there was flow. If you go to the diagnostic view after you got this, there was TIMI-3 flow.
No, show us the
sure.
view.
Yeah. So he knows the anatomy. He knows where to go.
You put the CTO cap on. I recall that. That view.
So this is the start. So the first operator was a non-CTO operator. And they tried wiring into the true lumen. However, this resulted in further propagation of the dissection, resulting in poorer flow.
Yeah, but you know the anatomy previously, sorry.
Where's the wire? No wire now.
No, I know, but you know the anatomy
now,
of the coronary.
I want to now enter. How do I enter?
I'm a bit biased because I was kind of trained to deal with these things by a CTO operator as well, so I would definitely use a SUO. So I don't think that approach is definitely the way to go, I think.
Abdullah, this is not a CTO.
Excuse me. This is, what you used actually is the parallel wire technique. 2 wires. For fenestration, you need to go in the sub-intimal by any wire, and you inflate the balloon, and by the other wire, to go from the sub-intimal to the true lumen. And what you did actually, you went with the stiff wire to the circ, and then you used a soft wire parallel to it without using the balloon. So this is not fenestration, this is parallel wire technique.
This is similar to the parallel wire technique, but, yeah, the plan was, the first attempt with a soft wire tip, there was no passage from the false lumen to the true lumen, so you have to create a fenestration.
How you create it? How did you create the fenestration?
Created it with the stiff wire. So the rotation of the
fenestration usually in fenestration re-entry is to use the balloon in the sub-intimal, and you go with other wire. So here the fenestration already done by the previous operator. Previous operator already inflated the balloon into the sub-intimal, and you went by parallel wire technique. And the idea behind the parallel wire technique is to use one soft and one stiffer.
I can guarantee you there was no balloon there.
Fenestration re-entry, you need balloon.
Yeah, but there's no balloon.
Hussam is here, I think, and he's...
Mohammad, thank you very much. I hear a lot of different debate about this. I think if you look at it, there was a hematoma probably on the proximal part of the LCX, and you had at that time TIMI-3 flow, and the colleague tried to pass the wire, and the wire actually caused the dissection. And then you have to be very, very careful of the circumflex artery because it's not an occlusion actually, it's a dissection. So you have a ugly, nasty looking dissection that is either a dissection E, is E because F is you have no flow. And I remember, the reason I remember F because I don't want to say the word, F is a bad thing, right? So it's E just one stage before F, right? And here I can rest assure you that the flow is down, it's TIMI-2 flow, and the patient is having chest pain. Now you have to do something. So then to do something is you need to gain back TIMI-3 flow in the vessel. I disagree with you utilizing a very stiff Gaia third, which is a taper tip, this bend, because you easily perforate and be outside the vessel, and then you have a perforation, the AV circ, and then you'll end up from a disaster into a more disastrous situation. But this was a matter of luck in here, because if you push the Gaia third, it's a directional wire, it could just perforate, and it's usually a bend in this area. That's number one. Number two, I disagree with Raed. This is not a parallel wire technique. Parallel wire technique is when you have a rock in front of you and you're trying to negotiate that. That term does not apply to this situation. Number three, the safest way in these cases is take a microcatheter, take polymer tip jacketed wire, and just knuckle, star it. It would go from false lumen into a true lumen safely. You have TIMI3 flow. ACs would come down. You wait. I won't do anything. Some people would do a drug-coated balloon, bring him back after a few weeks. Actually, we have a series of CTOs which we have done hybrids with we minimize the amount of the stenting. We stent just the proximal part. We've actually have 15 of them which we presented in a meeting in December that we bring them back and have a look. They actually heal, as my colleague have said. So try to minimize the stenting, make it safe, because these areas are like. So these are my comments regarding this case.
So many hands. بس كويك دكتور تفضل. الميكروفون عشان
One second. The other option, and this is you've done a great job, and everybody will give an opinion, and you've done a great job, and your patient's safe, and congratulations. One other option, because your wire's gone subintimally and you're in the subintimal space, is to do a straw Hassam. Yeah. So you've got a big hematoma compressing the true lumen, and it's very difficult to get into the true lumen. So one thing you can do is take a microcatheter into that hematoma and suck back, and just decrease the size, and it might help you get into true lumen.
Yes, thank you, Mohammad, for this case. I think, yes, he went subintimal, then true lumen back again. And maybe I'll do same like you. Maybe I can take a stiff wire like Gaia, because you know the course of the artery, where it goes. So the chance of perforation here is very, very minimal. And the second option, maybe you do a knuckle and just push it down to open the vessel. Maybe if you have a stingray, it will be your last option sometimes in such situation.
Okay. I strongly disagree with you. Because it takes you one case to perforate the AV circuit in this location, and you're done. So the Gaia people, so this is what happens. So, no, you get, how many times we get, where is Ahmed Khashaba? We did a case in Al-Qasimi. These circ are notorious. They're very notorious, and then we can debate as much as we want. So, and the thing is, people and companies would come and advocate, I have a new wire, Gaia Next 3, Gaia Third 3, whatever. I think your main concern is what is your objective? Your objective is to assess TIMI3 flow. You take a polymer jacketed wire, you do the straw as well, minimize the hematoma there, open up, Europe subintimal, intimate, but doesn't matter. You just shove it in the knuckle, it would find its place. And you can use that even in emergency situations. Possible, yeah.
I want to be much more provocative.
Okay.
Why we didn't put the wire in the left circ, just to protect the left circ when we are treating the ostium of the LAD?
Well, we weren't treating the ostium of the LAD. It was just the mid to distal LAD, so the proximal LAD was fine.
دكتور أحمد, last point, دكتور أحمد. خلي دكتور أحمد يتكلم. دكتور أحمد قاسم. 30 ثانية.
Yeah, this is my question. Because LAD lesion is mid to distal lesion, and you don't show something missing in this presentation actually. Why you don't show the lesion in the proximal left circumflex before intervention of mid to distal? Why this lesion happen? I think this is smooth narrowing, maybe scad in the proximal left circumflex, and maybe even the mid to distal is also SCAD. This is type 2 SCAD, which is similar to atherosclerotic lesion, and just provoking the more spread of dissection to whole circumflex. Something missing, I think, in the story.
As I said, I think the OCT catheter, when trying to advance it into the LAD, was prolapsing into the LCX. Sorry, I don't have any fluoroscopic images of this. The LCX was normal to start with. I think this caused the iatrogenic dissection. The thing that pushes you to intervene is the patient is having chest pain. And I think this pushes you to intervene and not wait and say that you're going to give it more time to heal.
Amount of interaction you got is great case. Thank you.
Dr. Mohammad, you did a good job. Marvelous. Thank you very much.